All right. Well, we're still waiting for Dr. Von Mayen, but I think we can get started. So, burning questions. Anyone who wants to start? Please. Thank you.
I've got a question for you, Beata. A very interesting talk this morning about your organoids and the role of epigenetics in that. Although you didn't quite prove yet the involvement of epigenetics, you mainly looked at organoid growth. I was just wondering, I've got mouse models of CBS deficiency. If we look just at the development of embryos, right? How I guess that a lot of the aberrant methylation reactions, etc., that only happens after birth, and you're really focusing on okay, what is happening, let's say, before birth, right? So how does the mother compensate? Is that a really an important mechanism? How do you feel about that?
That is an excellent question. I think it's something that there's pros and cons with both sort of mouse model and organoid model. So basically, you're right, we are looking more at what happens pre-birth and very early development. But it's sort of the best human specific model that we can get to date, other than actually going into human babies. That's especially relevant for the brain because mouse and human brain, there's some differences. So there's some cell types that don't appear in the mouse brain. So for example, you might know mouse brain is smooth, so it doesn't have these folds that human brain would have. So it's sort of the best available system to date. We do miss out on some maturity that you would have in a post-born human. But there are some groups working on actually how to speed up this maturity so that you can get closer to kind of a post-birth brain. But yeah, so it's not optimal, but it's sort of the best to date that we have that is human-specific and brain-specific. Yeah.
Thank you.
Thanks for the question.
All right. Got some questions in the back.
I also have a question for Beata. It's really exciting to see the advancement of organoid research in understanding brain development and brain function. I'm curious if you've got any thoughts on glial function and if you plan to look at glia or the interaction between neurons and glia within the organoid model.
Thanks a lot for the question. So it's not something that I work on, but I know of people doing the work. So there's some collaborators or sort of very closely working individuals that are now trying to introduce glial cells into the organoids because there's quite a lot of work in 2D neurons, 2D glia sort of separately. Putting them all together, that's a bit of a challenge because as you can imagine, you need slightly different environment for each of these cell types to thrive. But that's happening. So it's not something that I'm working on, but there's progress being made. And I think soon, yes, I do see that as potentially an important factor in, clearing homocysteine perhaps, or maintaining, I don't know, immune regulation, etc. Thank you.
Okay. More questions? More questions? You've got another one? Yeah. Okay. Why don't I ask a question since I'm out? This is one's for you, Julie. So great to see that Compose is now opening up a pediatric cohort. I was wondering, I noticed it only goes down to age 5. So I was just wondering, how did you decide on that cutoff? Are you going to be treating in the future potentially children less than 5? And what's different about that cohort, now that you have children compared to the adult cohort?
So let me start with your last question. So Compose Cohort 7 is an open label study, actually. So unlike the previous cohorts where there was at least one participant assigned to placebo, everyone's going to be receiving active treatment. And the idea is to study the PK and PD in the younger population. I I don't know. I've only been with Travere for about a year and a half, so I'm not sure what the whole history was around going down to 5, but there is also, plans to study younger patients in another study, uh, you know, after approval, hopefully.
Okay. You mentioned PKPD. Can you just explain a little bit more for the audience, what you mean by that in patient terms?
Right. So as my lovely slide said, right, PK is kind of how the body metabolizes and handles the drug, and including clearing it from the body. There's something called ADME. Well, so it's absorption. The M's for metabolism, and an E is for excretion. I can't remember what the D is for right now. Sorry. Distribution. Thank you. I know. And I'm like, I need a lifeline. And then PD is how different doses of drug relate to the effect you're looking for. In this case, total homocysteine change in the blood, in the circulation.
Okay, great. Thank you. So everybody, it is open label. So every patient in cohort 7 will get treatment.
That's correct.
Okay, very exciting. Who's next? Dr. Dielman, you wanted to ask another question? You guys got to think of questions, or it's just going to be, you've got one here.
Yeah.
Okay. You got to think, otherwise it's me and him.
Or we can have a break.
Sorry, Julia. I've got one more question for you.
Of course.
I think the essence of your therapy is that you're reintroducing CBS in the skin, and that this lowers total homocysteine throughout the body, right? I was just wondering, because I think that CBS also has quite local effects, like in the liver, where it may contribute to hydrogen sulfide production, local antioxidant defense. So I was just wondering about the balance. Okay, how's that? What is more important, local CBS expression versus just lowering overall homocysteine levels? I'd like to know your opinion about that.
I think that's a very important question. And as one of the talks this morning, I think someone made the point that is perhaps hard to tease out, right? But we're not going to biopsy organs, right, to see what the effect is. And that's where the animal studies and the animal models should help us. And those studies are also ongoing to see how to measure how pegtibatinase, when given to an animal model, lowers the circulating homocysteine as well as the tissue levels. All right, another lifeline. Would you like this?
So, sure, okay. I'll be a temporary expert, an ad hoc expert. So, in the mice, in our mice, which are different than yours, but I think they're pretty similar, we see that we can do gene expression where we express the protein in the liver, and that works really well. But Tomas, who has used the exact same mice for the preclinical studies, I got to tell you, he saw, he has to inject them twice a week, but he saw just as good an effect. So our thinking is that it is really homocysteine in blood is the toxic stuff. And everybody gives talks and they come up with explanations about redox and this and that. We know that giving N-acetylcysteine to the mice didn't really help at all. So we don't think it's a redox phenomena. We think that it's a homocysteine related phenomena. It could be related to the homocysteine interacting with cysteine and protein and screwing up disulfide bonding. Or it could be that Dr. Jakubowski is correct and that it's the formation of the homocysteine thiolactone, and that's really the toxic analog. But in all these cases, it seems like it's the homocysteine in the plasma is what correlates best with the phenotype that goes on. And we don't think it's, we've spent a lot, I mean, I've spent my whole career studying this. We don't think it's methylation in tissue because the ratios don't really change that much because you've got the elevated methionine causes elevated S-adenosyl methionine. That SAM-SAW ratio doesn't change. And we simply haven't seen, while there are local changes in gene methylation, which you can find with any treatment, we don't see anything systematic that suggests that's it. So that's kind of where it's at. So we think it is, that's why I think this treatment will, I mean, there are caveats to the treatment, which we discussed. You're going to have to give a lot of this enzyme. It's not going to be cheap. And, you know, but that all being the case, I do think it's likely to work. Not to plug Travere stock or anything, but that's, you know, that's my opinion.
Thank you, Warren.
Yeah.
Okay, we've got a question here in the back.
Hello, my name's Ruby. I'm 19. I've got classical HCU. I'm from Australia. This is about the Travere clinical trial that is going on. So it has just reached Australia within almost the last month. And I know that's for adults. And I just heard someone say it's potentially coming for children. I was wondering if that's just in the States or if there's a potential that it's like, is it going to children? Is there a chance it's going to children?
Oh, to children.
Yeah.
It's open to 12 to 65-year-olds.
Okay.
So, yes.
Yeah.
And Miriam is going to rescue me yet again.
Thank you. That was a really good question. It gives me more opportunity to talk about the studies. So yeah, we're very excited. Harmony has opened in Australia recently. Cohort 7, the 5 to 11 cohort, is not going to be conducted in Australia. I know we've had a lot of inquiries about that. It's the footprint that you saw earlier for Harmony, that's a Harmony footprint. For Cohort 7, it's a smaller. It's still global, but a fewer countries than what we have for Harmony.
Is there a potential in the future, if it were to be successful with like pediatric patients in the US, that it would go internationally or it would stay?
Right. Yeah, no, it's a good question, right? The question was if, you know, is there potential for it to expand into Australia? Right now for our current plans, because of the timeline of the study and the patients that we're enrolling, we don't currently have plans to expand into Australia.
But that's with the trial. If the overall program
trial,
is
yes.
successful, right, then, you know, then that opens the doors to treat younger children, and that will have to play out over time.
Yeah, and remember, Harmony is open till 12, right? You said 12 up. So kids who are above 12 can still participate. Okay. I like it. Everyone's now got the wheels turning, right? Thinking about their questions.
So I'd like to preface that this is a question from my husband in case it's a dumb question. He's not here. He texted me. Are any of you in your research and studies using biotechnology tools like CRISPR or different AI programs? And if so, like, is it helping? Is it advancing? Is it cutting your timeline down?
Timeline, meaning trials, or,
Like
you know,
going from
clinical
animal
studies.
trials to human
Yeah.
trials, yeah.
Yeah. I mean, yes, I think AI is, you know, touching every part of every industry, quite honestly. And we are looking for ways to incorporate, you know, AI writ largely into what we do. That being said, I mean, you know, but CRISPR is a different
Yeah,
issue,
that's more gene
right?
editing,
Yeah.
I think.
All right. And I'm going to steal that line about your husband's
It's true.
question and why it might not be great. Okay. So I'll stick with the AI. Yes, we are looking at ways of using AI to accelerate what we do, because really the focus is on bringing these important new therapies to patients as quickly as possible, while still establishing that they're safe, of course.
CRISPR's big.
Yeah.
Yeah, and it sped up the time to make a mouse.
Well, so that's helpful.
Absolutely, absolutely. It's huge.
We use AI quite a bit at Syntis to help like model some of our polymerization kinetics and translation from mouse to rat and those sorts of things as well.
Yeah, in my case, I think CRISPR was very important in just making cell lines, so knockout lines, and there's a lot of sort of correcting of the cell lines. Yeah, so CRISPR is very heavily used. AI also, yes, but mostly for personal use. So, so I don't know if that counts.
I actually want to use that as a question to turn it around and a little bit on the current study that's ongoing. With CRISPR technology, obviously it's a gene editing technology. And I think that's for me also a bit of the thought process, and also with the work that we do. How many of your cells do at the end need to have the treatment, do need to have the correct genetics set up? And maybe if you do an enzyme replacement therapy, how much do you need it? And I think that's a key question. I'm not sure if this is really properly answered, because I would put that way, a gene therapy for an affected individual being adult or a child being born is close to impossible if you want to target all cells, because you won't get it to every cell. And I think that's where enzyme replacement is very powerful, because it's easy to deliver. But even there, I don't think you can deliver it to every cell and every tissue. If it would be brain specific, I think there's challenges. But the question is, do you actually need that? And I think the discussion you also put on there is, are the dosages the relevant part? Can you affect 20% of the cell, 30% of cell? Would that be sufficient to treat something? And if that's the case, maybe a genetic intervention, a CRISPR gene therapy could suddenly become quite interesting. And I think that's something on the research side needs to be explored. And I think maybe also as a community, we have to think about what is it predetermining, working out what do we need, and based on that. And I think all of these new tools which are out there, they are quite interesting because they really allow now in a much more precise way to change the genome. And so I think, yeah, I mean, and that's something definitely many do, we do it. And the idea of doing human, it has challenges, but I think it's a lot of potential too. And the AI, I think that's, I can't think there's any place in anywhere from economy to research where it's not applied. But I don't feel it's kind of transforming in a sense of things you could not do, it just faster.
It's actually for Ken, but Ken is not here. So maybe others, Warren, yourself, or Dr. Dielman can jump in here. But I was really intrigued with his discussion. I've heard part of the Form 8 discussion before, right? In the taurine discussion. And half of what he said went over my head, but it looked like there is an interplay, my words, with that whole metabolic chain and how it affects sort of that, as he put it, the exhaust pipe and the ability to purge and the ability to affect bone mass and bone growth. And that's pretty close to home for us, because although both of our children were diagnosed at early and well controlled, they've had different effects on their skeletal result. And I'm just curious, and Ken's not here to ask, but, and I don't want to put anyone else on the spot, but are there thoughts on could that Form 8 taurine treatment or anything over on that corner of the metabolic chain really have an effect on what he was discussing? If my question makes sense.
So I think not the right one to answer that, because it's really not what we have looked into. So I could just speculate, but I'm not sure if anyone.
We would all speculate.
I can't give it a reasonable evaluation at this time without having seen what he showed. So the answer is, yeah, these are complicated pathways. There's lots of, at a very general level, there's a lot of feedback that goes on. And so if you tweak something somewhere else, it can affect through regulatory mechanisms what happens elsewhere. And so sometimes it's not inconceivable that there might be something important. The only thing we can say is that in terms of where taurine is, so taurine is downstream of cysteine. And so when we give mice that are CBS deficient N-acetylcysteine, which is a cysteine precursor, it didn't help. It didn't, and that should also be a taurine precursor, but giving it and making it, there are different things. So I would never say Ken was wrong.
No, I'm not putting you in that spot. I thought his talk in your midst was intriguing, and I was just curious.
I think he also discussed that. I think he also mentioned that some of the variation in the response might be related to polymorphisms in specific enzymes of the folate cycle. I think, yes, that could be true for patients, obviously. But what we see also in mice is that there's quite a bit of variation in response. So and those mice are genetically the same. So yeah, it might be these types of polymorphisms, but we also see other variations that we cannot just explain by genes and genomes.
If I may, are those differences consistent within those mice? In other words, they have something in the background that makes them different, even though they're genetically the same?
I can't tell. No.
I like to tell people there are three fundamental things in biology. We have genetics, we have environment, and then we have stochastic randomness. And you can't underestimate randomness. It occurs. You can take things that are genetically identical. You have these mice growing up in the exact same environment, and one mouse will have a homocysteine of 400 and its brother will be 250. Well, what's causing that? I don't know. You could say, well, it's when they ate less or this and that, but the reality is it's just something you have to deal with. And the only way to deal with it is to have a lot of numbers. And that's hard to do.
Hi, Ashley. I have a quick follow-up that I just thought of. The 24-hour clearance time that you mentioned for your product, is that from the data from the study that's in clinical trial now, that's human data, or is that from the animal models?
So we have confirmed it in humans. Actually, when we first started administering scent to humans, we endoscopically delivered it. And then we went back in 24 hours with the endoscope and confirmed that it was gone. But there were data that suggested that it was still there, like at least 12 to 18 hours. And then again, in our preclinical models in the dog, we've confirmed via barium sulfate studies and PillCam studies that it's there for about, it's a range 12 to 24 hours. We never see it after 24 hours. And then we've done like necropsies in rats and mice to show it's generally, it's faster obviously in mice, but around that 12-hour range in rodent models.
Okay, so do you think you would then target a once-a-day dose or potentially twice a day?
Once a day is our hope. Specifically, if we can get within that 12-hour range, that's really optimal for dietary reasons. I think 12 hours would be optimal.
Okay, thank you.
Thanks.
Julie, I had a question for you about the hives that people exhibited in the study, and I can't remember actually which music themed when it was now because my caffeine is wearing off from this morning. But I'm curious about. I know that people those resolved or whatever the hives. You said one was was it the peg itself that people were do you know what part of the treatment was causing them to have the hives, or has that not been ascertained? Or can you not tell us?
I'm just, again, these studies were completed and our medical monitor could probably answer that question more. But, again, they did resolve when there's a subcutaneously administered drug, it's very common to have, injection site reactions. But it's specifically about the hives. I don't have particular insights in that. Maybe Dr. Bill Rote does. He's getting up. Get so many lifelines. I love it.
Yeah, no, it's Bill Rote, Chief Research Officer at Travere. It's a great question. We don't know the answer. So there's some antigenic allergic response to the vast majority of the patients that have been administered pegtibatinase. We have not seen hives in the current protocols. Patients are pretreated with antihistamines, and which is very common with other enzyme replacements or sub-Q injection of large proteins. Because we're administering a version of a human protein, theoretically it's less antigenic, but it's made in a different way, so it could be. But it's coated with a lot of polyethylene glycol, which effectively hides the enzyme from your immune system. So it's less likely to be recognized. Doesn't mean it's never going to be recognized. So we do see some of that. But when we look across other large protein administrations, especially non-antibody, and certainly with enzyme replacements, our level of antigenicity is really low, and the tolerability is higher than what's been my experience in protein biologics given sub-Q. And it's also very encouraging that we were able to, give that patient antihistamines, let it calm down, redose, and not only were they able to restart, they stayed on it for a long time. So it speaks to the tolerability. The PEG's doing its job, and it's not, an enzyme that's coming from an insect or from a different mammal, which I think is very helpful in that case as well.
Thank you, Bill. Very helpful.
That's great. And patients now have been on therapy for years, right? How long? And tolerating it well? Wow, amazing. Okay. Any other questions? Okay. Why don't I ask the last question and then we'll end the session. So we are here at the conference, and we will be doing this conference again in 2 years, right? And hopefully having you back here to tell us what has changed. So I would like to hear from each of the speakers, what are the biggest challenges you see between now and then, and what do you hope to come back to this conference and tell us about next time? So we start with you, Julie. Go ahead.
Well, I think the obvious answer is that there will be an approved treatment for classical HCU. That's what I think we all hope for. It is a long, road, and it is a not and smooth road. There are a lot of considerations and challenges, but right now we're very much focused on getting the trial fully recruited, which again, would be great for the community to pitch in with that however you can, any suggestions you have, etc. Just raising trial awareness again. So I'll pause there. Thank you.
All right. So I think in terms of the Syntis technology, the biggest hurdle we're facing right now is reducing the dose. Like the paper that came out originally describing the engineered enzymes showed, some doses up to, nearly 40 to 100 mgs per kg. And so we're working on reducing that dose so that it can be a once daily oral tablet. How we've been working against that is by compressing these into tablets rather than using capsules that have like a really fluffy, filled enteric coating. So I would hope to show you in 2 years that we have a once daily tablet with our phase 1 data, since we're trying to gear up for that next year.
So I think in basic research, the biggest challenge is often just optimizing and establishing the methods and techniques. So I think that has been more or less overcome by now. It has taken years. So I think now things should start coming in, and we should be getting some data, interesting data coming soon. So hopefully we'll, in the next 2 years, we'll have some sort of uncovered mechanism of what happens in neurodevelopment and remethylation disorders, and what mechanisms are affected, and maybe what alternative targets could be studied to actually look at treatment or kind of alleviating the symptoms and phenotype. We're also looking on the other side a bit into diagnostics. So in, Fernand mentioned in his talk as well that looking for alternative biomarkers for newborn screening. So if that works out, maybe also potentially something new for the field to incorporate or introduce or
I can just continue on that part. I think for us, it's basic biology. We want to try to understand the mechanism. And a few talks that I've seen today, and I think before we had the talk that you had your question about, I think many times we go into a very complex system and we try to work on that. We've kind of taken the other approach, going to a very simplistic system in the first place and being able to look on that. And I think these two combined will give us really a lot of potential to better understand the thing. I think we cannot leave one or the other way. Both have its benefits and disadvantages. And I think that's for us the hope that with the systems we have, we can actually then start combining many things. We can basically, I alluded briefly before when I was saying the CRISPR technology, we actually can do mixing experiments. We put in diseased, non-diseased cells together and test what ratio would be sufficient to have a normal growth versus non-growth. And I think these kind of experiments that we're thinking about doing, which maybe give us ideas for then therapeutic, for applications, telling you that's actually maybe the target, that's what we want to achieve, that's kind of what we need to achieve for successful treatment. And I think then other groups here working on animal models or kind of better understanding the disease in a more physiological setting, really validating, building on that, and actually their experiments also going to us. And I think we hope at the end, particularly with the work we started, having a nice platform we can validate, we can test potential new treatments, and giving some insights into what is happening and what are potential really key mechanisms that we need to target to better understand.
Awesome, great. Thank you so much. Let's give a big round of applause to all of our speakers. Thank you for your time and coming out here.